I now request Dr. Palaniappan to come to the stage. It's very difficult to introduce someone who doesn't need an introduction. He comes with a bang, with lots of music and lots of subject. A namesake of a legend, Dr. Palaniappan. He is very good. He is very, when he delivers a lecture, I think everybody will be listening to him very intently, enjoying his lecture. You can see lots of awards and all these things. I really wouldn't like to waste my time in mentioning that because his speech will be more attractive than his awards. Thank you.
Good afternoon, ladies and gentlemen. I'm sorry I'm standing between lunch and you, but anyway, I'll keep it a little bit interesting as the generous introduction given by Dr. Balakumari. And at the outset, let me thank Aruna and Ashok immensely and profusely for making me a part of this wonderful program in spite of a parallel program going on in another hospital. We have a huge crowd here, and thank you all of you for being here and being the last session on lunch. And thank you, Vairamala, for that lovely lecture on cervical insufficiency and cervical stitch. I thought it was a debate, but then I learned a lot of things, but then I didn't know that it was a lecture, and thank you very much for lecturing me. A stitch in time saves 9 is an old statement which all of us know. And cervical encirclage routinely done for IVF pregnancies, or should it be done, is a question, and the answer is a big no. And over the next 7-8 minutes I will convince you why we should not do a cerclage routinely for all IVF pregnancies, and we have enough evidences and more. This is a stitch, and it's not very easy to go ahead and stitch the cervix, and it is as difficult as this. And as soon as they came, I asked them to remove the podium which was there, because I thought we don't need a support from below, and that's exactly what I'm here for. And Vairamala needed a support, and that is the cervical stitch, and we don't need a cervical stitch, and that's symbolic to start with. And we'll end with that also, and I will convince you with that as well. There is a ribble, whether it's worm stitch, McDonald's, Shirodkar, or Benson and Durfee's abdominal cerclage. Oh, it can't stand in Jurassic Park because there is a ribble. The so-called aim of a cervical stitch is to give mechanical support to the cervix and probably reduce one risk of preterm birth, and that's all is the idea of putting in a stitch. May be indicated in few IVF pregnancies and not all cases as a routine. May be indicated in a previous preterm loss, a septate uterus which is corrected, an anomalous uterus, maybe a short cervix less than 2.5 centimeters, as what Dr. Vairamala did mention. This is a picture, this is a study which came out, which you mentioned just like that, but to your support, I will answer this. Cervical cerclage before a blastocyst transfer in patients having cryopreserved embryo transfer. You can see the conclusion. This came out in Fertility Sterility, one of the papers which we all flaunt for. Cervical cerclage can be performed before blastocyst transfer in patients with cervical insufficiency who undergo cryopreserved embryo transfer. The procedure is especially relevant to patients in whom the cervical os is dilated and the distal cervical segment is short. Very clear conclusion. Unless and until you have a short cervix and dilated cervix, you don't have to stitch it. A ripe fruit will fall anyway. You can't prevent Newton's third law. You cannot prevent the fruit from falling, and you can't prevent that baby to go into preterm labor. If the cervix is dilated, then you go ahead and do it. Transfer of a single high quality blastocyst can result in pregnancy and birth. This is a very recent article which came out, and so you can do a cerclage if there is an indication, whereas a prophylactic stitch, no. What complications of a routine cerclage which you do for an IVF pregnancy? Oh, anesthesia. You have to give anesthesia. You can't do it without anesthesia. You are prone to have an infection, maybe a PPROM, maybe a vaginitis, maybe pyrexia of unknown origin, bleeding, maybe preterm premature rupture of membrane, and of course preterm labor in spite of you putting in a stitch, cervical stenosis, scar on the cervix for whatever reason further on. If unattended during a preterm labor, the cervix can tear, or pyrexia of whatever, you could have a cervical dystocia. Please understand, by putting on a stitch, you are damaging the cervical glycosaminoglycans. Not that when you remove a stitch at 37 weeks, the cervix will open and she's going to have a vaginal delivery easily. No, not at all. You have spoiled the beautiful cervical glycosaminoglycan matrix, and so she will go in for a cervical dystocia, and you may have to do a C-section. And later on, she can have a fistula formation, why we will see here. What Vairamala is thinking here is, ladies and gentlemen, I know this hall is filled with a lot of infertologists, IVF specialists. Please don't throw stones at me outside because I'm going to talk evidence, and I'm not against you. I'm everybody's friend. I don't know why they put me always on a debate. But what Vairamala is thinking at the moment is, anesthesia. I help my anesthesia colleague by calling him inside. So is Ashok. Infection, I help my pharma colleague by prescribing a higher antibiotic. Bleeding, I help my blood bank by ordering 2 or 3 units of blood. Okay, let's help. PROM, baby is delivered at 30 weeks and keep in the ICU, and I help my neonatal colleague and help the neonatologist and the NICU. Cervical stenosis, I don't do a vaginal delivery at all. Why have you worried about cervical stenosis? I will anyway do a cesarean section. Scar tissue, cervical tissue, they are futuristic. Why should we bother now? We can refer to a tertiary care center later on. A scarred cervix cannot do a vaginal hysterectomy in the future for any other fibroid or whatever case, or doesn't matter now. We will do a TLH anyway later on. So you have betrayed this particular patient for all these conditions, and we have benefited so many other people rather than the patient by putting in a single stitch which probably was not indicated, saying that it is going to be a prophylactic stitch. Will help everybody, but will you think of expenses for the patient is a question. It matters. Money matters matter. Cerclage success rates, please understand, ladies and gentlemen, reduction of a preterm birth is only 39% to 43% in the most searched literature wherever. You cannot have a success more than 40% by putting on a stitch, whatever method, whatever cerclage, whatever suture material you use though. Complications from cervical cerclage, 3 randomized controlled trials, 41 cohort studies, 4,511 women on transcervical cerclages. Hemorrhage was almost 3% published in contemporary OB. 3%, okay, 2.3%. The process types of cerclages indication suture materials were analyzed, and they said the incidence of vesico-vaginal fistula was 2%. We don't look into literature, and because of the debate, I had to look into the literature, and the incidence of EVF is 2% in these cases. Perioperative complications of a transvaginal cervical cerclage in singleton pregnancy, systematic review and meta-analysis. So many studies, 3 randomized controlled trials. Hemorrhage was 2.3 and PROM was 2.5%. American Journal. Very recent evidence 2022. Please understand that in spite of you putting on a stitch, you can have a PROM. Oh, she's going to say now, IVF, most of our patients are twins. Why can't we put in a stitch because it's a twin? Coming back to the next conundrum of a twin pregnancy. Agreed all IVF pregnancies, maybe they are twin pregnancies. Do they need a prophylactic cerclage is the next question. I've addressed that particular separately. Cerclage for women with twin pregnancies, a systematic review meta-analysis by the American Journal. Came out 2019, not very old. 16 studies, 1,211 women. Benefit of history indicated or twin alone indicated cerclage is less certain in twin pregnancies with a normal cervical length. So ladies and gentlemen, we have evidence. You and me don't have time to sit and do a study, but then please follow some study which has come into, and so there is no evidence that putting on a stitch will prevent a preterm birth in a twin pregnancy. The Green Top Guideline 2022, she also quoted it. It is given in a different statement, but please understand the statements exactly. Women with no other risk factor, cervical cerclage is not recommended in women who have an incidentally identified short cervix, which is one of the conundrums of the case which we are going to discuss. Insertion of a history or ultrasound indicated cerclage in women with multiple pregnancies is not indicated. He's very clearly mentioned multiple, maybe a triplet, I don't know. That's not the debate. The debate is a twin, and so it is not indicated. So GTG says, please don't put on a stitch for a twin pregnancy. All IVF pregnancies, do they get progesterones or not? I'm sure everybody in this hall use progesterones orally, vaginally, intramuscularly. If there is an ocular preparation, we'll use it into the eye, into the mouth, into the rectum, into the nose, everywhere we will use. That's not the debate today. Oh, ladies and gentlemen, we have progesterones ready everywhere, all around the corridor when you walk out. We have progesterones ready always. Oh, the American College did say, updated clinical guidance for the use of progesterone supplementation for the prevention of recurrent preterm birth. What did they say? They said vaginal progesterone may be considered as a treatment option. The debate is not that. Intramuscular 17-hydroxyprogesterone caprate is not recommended for the primary prevention of preterm birth. This is a very recent recommendation, 2023 April, okay, just a couple of months back. And so they have said you could use progesterones for prevention of preterm birth, a very clear recommendation. There is no doubt that you can use progesterone. Probably the only strongest indication for the use of progesterone is prevention of preterm birth, and if so, especially in a twin, especially in an IVF pregnancy, which we all use. Then why do cervical cerclage at all, ladies and gentlemen? It's of no use doing a stitch which is unnecessary and which is routine and which is prophylactic, absolutely not indicated. Ladies and gentlemen, I never lose. Ladies and gentlemen, thank you very much. I never lose. I either win or I learn from Vairamala. Thank you very much for the opportunity.
Dear speakers had enlightened how their vision of cerclages. I think the topic was chosen because sometimes we feel very guilty after a third embryo transfer, a patient conceives. And I know that ethically we have to put single embryo, single blast. Every other IVF specialist wanted to have a singleton healthy pregnancy being formed, and never we wanted to have a twins and have a preterm delivery and they spend lakhs in the ICU. But due to the emotional blackmail and emotional facts that at least first time we can put a single, but if they fail we put a 2 embryo on the second, and then if they turn out to be twins, and when they come at 2 situations. One is when they come, the cervical length at 16 weeks is superb, it is 3 centimeters given by the sonologist, and 20 weeks they land up in your clinic with the bulging membranes. And then you are guilty whether you lost the chance of putting a cerclage, and if you had put a cerclage, you would have saved the patient or baby or not, because it's a very precious pregnancy which we are handling. This is one situation we regularly have a guilt about it when we don't do a cerclage and the patient expels the baby at 20 weeks. And the next situation is, we have not put a cerclage and there is a good scan at 24 weeks, there is a good cervical length being noted, and 26 weeks or 28 weeks the baby is getting delivered, and the patient has to spend lakhs, maybe a few lakhs or more than that in the NICU, where they could have spent some thousands to do a cerclage and maybe we would have postponed the. This is the evidence. We very well know that we are not talking about indicated cerclage. We wanted to talk only about prophylactic cerclage when the cervical length is good and there is no history recommending cerclage. So this dilemma, we definitely, and sir has pointed rightly that we need to do a study without doing a cerclage, how many of them with a prophylactic cerclage, and without a prophylactic cerclage, how many of them in our own population. But we wanted to get the opinion from the speakers, so I think somebody can opine, seniors also can opine. We hand over the phone.
Left to me, I am in favor of Dr. Palaniappan. Doing cerclage just like that for everybody is not an option. See, the sensitivity of the cervical length itself is only around 30% for a singleton pregnancy, and it's around 15% for a twin pregnancy. Means even a short cervix will remain closed till the delivery for many of the women, 70% of the women. And the success rate of the cerclage, again Dr. Palaniappan had said, it's only around 30 to 40%. To save one preterm delivery, you will have to do 25 cerclages, which is not justified. Okay. And again, I'm sorry for differing with you, saying IVF pregnancy, it is precious, so we do it. Every pregnancy is precious. Whether you conceive by IVF or in the natural way, every pregnancy is precious. So I think I will not take up that statement of being precious, so I am putting a cerclage. So I am in favor of doing cerclage, only indicated cerclage.
But she's on progesterones, please get the point clear.
Yes.
Every patient is on progesterone, and so please believe the drug. For once, believe progesterone on this particular condition. They work here. and we have enough evidence. And we give progesterone for where all conditions it doesn't work. But here it works, and it really works. So please, you'll anyway use progesterone.
The debate here is for the post-IVF FOGCE twin pregnancies rather than the spontaneously conceived twin pregnancies, where there's extreme high rate of preterm births and expulsion of both fetuses even before the period of viability in IVF FOGCE pregnancies. And the compliance of the patient is also all the more important when there is regular medical follow-up. And there is a relative risk which should be offered to all pregnant. That is IVF workup. When there is infertility workup, the patient should be aware of this, and the choice is most of the women ask for this cerclage, which at least as the last choice or the last weapon for us to protect the fetuses. Okay,
Want to put the flow chart, madam? So, no, we can put the flow chart. Case scenarios or flow chart? So already we have done with the case scenarios. I think what we wanted to tell as a take home is we have to do serial cervical length monitoring. I know every other pregnancies are precious, as madam has told, but it is not there that many a times the obstetric report doesn't have a cervical length in their mention. After 20 weeks or 16 weeks, they don't do the cervical length screening for the patient. So along with the anomaly scan, we have to get the cervical length also being done. And I think this will help, and Dr. Balakumari can.
Just to sum up, you take the history, do an NT scan, do a cervical length measurement during that time. If the length is normal, if the woman has had more than 3 abortions, then 3 second trimester abortions, or one of which can be a preterm delivery also, then you consider a history indicated cerclage. If the woman has had a vaginal cerclage already, then go for an abdominal cerclage. Now, coming to the other category where the cervix length is 2.5 centimeter. Okay, if it is less, if there is no previous history of second trimester or loss or preterm birth, you will monitor her. You go for a serial monitoring. The only category of women who are benefited definitely are singleton pregnancies with the previous second trimester loss and a short cervix length. All the 3 combinations, if they are present, they are the only. All the other people, you can definitely take them up for serial monitoring. Serial monitoring, again, how do you do? It is roughly around 1 millimeter length can be shortened for a normal pregnancy. Supposing at an NT scan, the woman has a cervical length of say 3.2 centimeter. Okay, that is 32 millimeter. By 20 weeks, that is 8 weeks later, if her cervix length is around say 2.5 centimeter, it is not again an indication for surgery. Okay, if the cervical shortening is more than 1 millimeter per week, then you can take up. The shortening is more quicker, so you can take up. And the other thing, the physical examination indicated cerclage, mainly because the sensitivity of the cervical length is only around 30%, which means the 70% of the women who had a normal cervical length can also go for a preterm delivery. So when she comes with a history of lower abdomen cramps and then discharge, you find a cervical length of less than 1.5 centimeter or an open cervix, then you go for it. Again, supposing you diagnose at say 28 weeks 2 centimeter or 1.5 centimeter, you don't have to go for a cerclage. You can give steroids and then wait for the spontaneous progression.
So we'll move on to the felicitation of the speakers. It was a very interesting session. Definitely before lunch it was worth the wait. So we now request Dr. Arna Ashok to please felicitate Dr. Vairamala Madam. And Dr. Balakumari Madam to please felicitate Dr. Palaniappan sir.